In looking at past research at the University of Melbourne, it's important to remember that the university was founded on the colonial frontier. So it was founded in the few short years between the Wurundjeri head clansmen signing the treaty with Batman in 1833 and when the surviving Wurundjeri moved to Corranderk Mission in the 1960s. Sorry, the 1860s. On this slide, I've included researchers at the University of Melbourne, and I've selected 4 because I think they very much reflect the research that was conducted at that time. And I've included the names of some of the studies that they were involved in. So the first person on that slide is Richard Berry. He was an anatomist and later Dean of the University of Melbourne at the turn of the 20th century. His research was very much focused on the pseudoscience of phrenology and the measuring of skulls. And he used a lot of skeletons and ancestral remains to conduct his research. And he used them to make observations about Aboriginal people's inferiority. And it's very troubling and shocking research and reflection. I think it was only in 2003 that the extent of his collection was realised when the University of Melbourne in their anatomy department discovered over 400 cranial belonging to Aboriginal people locked in a storeroom. I think they've since been provided to the museum who's trying to repatriate some of them. The second researcher is Walter Baldwin Spencer, a professor of biology and anthropologist. His research mostly took part in the Northern Territory, including where my family are from. His research was conducted at a time when scientists wanted to know more about Aboriginal people because they assumed that they were a dying race. So they wanted to know much about this culture that they could. An example of his work includes the Arunta study of the Stone Age people, a title which alludes to his belief around Aboriginal people and their primitiveness. He was later appointed to the role of protector of Aboriginal people in the Northern Territory, so he really was seen as an expert of Aboriginal people. And the policies and that he came up with really had big impacts on people. And I think that's one of the things that we need to think about is, as researchers, what that knowledge, the change that it can lead to, both good and obviously very bad. The next researcher is Karen O'Day. So Karen's one of the first generation of female PhD graduates from the University of Melbourne. She graduated in 1971, and prior to that, it was mostly men who worked as researchers. Her research on the slide is an example about metabolic outcomes and traditional diets, and it marks a move towards more interventional research and about improving health outcomes for Aboriginal people through research. Prior to then, it was mainly about collecting knowledge to better, build mankind's knowledge. The last one on that slide is Professor Ian Anderson, Apollo man, and he's one of the first Aboriginal graduates from the University of Melbourne, and he graduated in 1989. He was the first medical graduate. He also established the Nemda Kuru Health Unit at the University of Melbourne, and his research there, Kuru Health and Kuru Hands, an orientation manual for Aboriginal health and healthcare providers. It's really underpins his community development and knowledge exchange approaches. And what I wanted to sort of show with this slide is this has been 100 years and a lot has changed in the evidence types of research that are being created. What I really wanted to understand in my PhD is what have been the drivers of change? So what has led to this change in how evidence or research is created? One of the main things I wanted to do was look at the social context in which research and also evaluations are produced. As this slide shows, there have been many changes to the lives of Aboriginal people since 1945. So they've gone from state-sanctioned Aboriginal acts to Aboriginal people entering the academy and parliament, families and communities living with greater civil rights, land rights, self-determination and Indigenous rights, but there's obviously still a lot of work to be done. This period is also important in terms of self-determination, as it marks a time when Aboriginal people were setting up their own health organisations, their own social organisations, and also their own journals, and even the Research Institute in Lowitja. What I really wanted to emphasise here is that research is a product of this environment. Research practice change and evolves as a wider context does. Previously, there was limited control. Research was conducted without us, on us. Now it's expected that Aboriginal research and evaluations be done with, for, and by Aboriginal people. In reviewing past research, it was clear that there were really two key drivers changing research practice. The first was Aboriginal people themselves driving change for themselves and their community. Aboriginal people have fought hard for equal rights, land rights, the right to self-determine, and right to participate in decision-making. And a lot of the changes to research have come about through ethical guidelines. And those guidelines themselves came about because Aboriginal people in the 70s and 80s met with governments and universities and really demanded greater control of research. And the second factor has really been changing research. The second factor changing research practice has been new ethical guidelines and practice. So since 1945, there's been far greater regulation of research practice generally. Prior to 1945, research practitioners were largely guided by the Hippocratic Oath to do no harm. But then there was global research instruments with the Nuremberg Code and the Declaration of Helsinki, and also national ones such as the National Statement, and also Aboriginal and Torres Strait Islander specific guidelines by the NHMRC and these guidelines really outline that Aboriginal people need to be leading and including in decision making. So, in my review of past research, the two key messages from the review were that firstly, that research is socially produced and changes within the socio-political environment. And the second is that Aboriginal people have demanded greater agency, self-determination and voice in decision-making. The structural changes, including regulation of practice, policy and guidelines, have also been instrumental to changing that practice. The second part of my research really looked at present evaluation research and evidence-based practice. So for the first, I did 3 publications throughout my PhD, and the first one was essentially an evaluation of evaluation practice. This was done back in 2018. I took quite a while to do my PhD. I ended up having children and COVID disruptions, but this was the first paper, and it looked at how well evaluations were being done. So what we did for this paper was we looked at all the state government and national government policies, the health planning policies, and looked at what they said about what values and principles should inform the work that's being done in Aboriginal settings. And the idea is that if the government says that these principles and values are important to the work they do, then they should be underpinning evaluations that governments tender out and do. So in reviewing the documents across all the states and territories, we found that the principles of shared responsibility, cultural respect, engagement, partnership, capacity building, equity, accountability, evidence-based and holistic concept of health were all outlined by Australian governments as important to the work being done in Aboriginal and Torres Strait Islander settings. I think it's very important to note that governments say that engagement and partnership are very important to the work they do. This means they should underpin evaluations that governments are tendering. What we did is we identified all government tenders that were released during 2007 to 2017. We found 390. We were only able to access 97 that were publicly available by searching. So, I mean, this in itself is a finding in terms of the availability of evidence. But of those 97 evaluations that we did look at, we found that the principles of evidence-based equity and accountability were the ones that were best integrated into evaluations. And I mean, that's not really surprising because it sort of fits with the closing the gap policy agenda and the overarching sort of objective to build the evidence base, address disparities and achieve health equity. But in terms of engagement and partnership, there's over a third of evaluations that had no engagement with Aboriginal people community. And this is really revealing about the absence of voice and control in evaluations. And in terms of partnerships, less than half had a partnership approach. As part of the work that we did for that paper, some of that appears in an evaluation framework to improve Aboriginal and Torres Strait Islander health, which the Lowitja Institute published. And that's a useful document which really focuses on the essential elements of evaluation planning and practice and what's needed to undertake evaluations in this area. The second paper that I did was looking more at evidence-based practice. So this is what came out of the Victorian Aboriginal Childcare Agency Partnership and their concerns that current evidence practice was not meeting their needs. So at the moment, this is a past policy, but has since been updated. But at the time of doing this research, Australian governments were increasingly focusing on evidence-based practice. And what that means is that evidence-based practice is premised on the concept that best research and evaluation should inform decision-making. So in terms of evidence, best research and evaluation. But the key criticism of this is it's developed for the field of clinical medicine, and it's often used to answer very simple and focused questions in context. And it's very different to the social and welfare context. In terms of our criticisms with evidence-based practice, I think the main concerns came from its uncritical application to the Aboriginal and Torres Strait Islander setting, largely wider environmental and organisational and the context that it occurs. In the context of Australia, it's dominant governance and universities that are resourced and empowered to produce research and evaluation evidence and reviews these, not the Aboriginal community-controlled sector. Where Aboriginal and Torres Strait Islander organisational values and preferences are sought, it usually takes the form of consultation, engagement and partnership, where ACCHOs most often lack real power in decision-making. In contemporary evidence-based practice, ACCHOs are not at the forefront of decision-making. It's Western-trained practitioner experts, largely in government and universities. It is they who systematically locate and appraise Western research and evaluation using their own guidelines and tools and present these as best evidence. In this paper, we identified our concerns regarding how best evidence is determined. So in terms of evidence-based practice methods, these are very much Western evidence-based practice methods. There's numerous evidence-based practice guidelines. So you may be familiar with the NHMRC How to Review the Evidence, or the Cochrane or Joanne Briggs Institute, or the Critical Appraisal Skills Program. These all have a set of guidelines that usually have a few systematic steps that talk you through doing an evidence review. So there's, in the blue box, there's the 4 steps for doing an evidence review. It says you develop a question, you acquire relevant studies, you appraise and select quality studies, and then you assess it to how applicable it might be used across different populations and settings. In terms of this, we sort of worked through all these 4 steps and highlighted why some of these things can be problematic in Aboriginal and Torres Strait Islander settings. The main thing with developing the question is we're very concerned with who gets to ask the question. Developing the questions of an evidence review requires humans framing formation of the questions, and who is legitimised as practitioner expert matters, as does their social position within the environmental and organisational context, their proximity to the population, and their authorities to speak on behalf of the population. So people from a university, people from an Aboriginal ACCO, they may not always ask the same questions. They might not define the population of interest in the same way or see a problem in the same way, and also have different responses and have very different ways of seeing outcomes. Cultural outcomes may be more important for an ACCO, whereas educational outcomes may be more important for those in a university. We also know in the past that expert practitioners have tended to formulate questions using a deficit discourse, and this has problematised Aboriginal and Torres Strait Islander individuals and communities. Aboriginal people and organisations should be leading the question formation and identifying how populations, interventions and outcomes are framed and designed. The second step relates to acquiring relevant studies. One of the things that I'll show later is that there really isn't a lot of randomised controlled trials conducted in Aboriginal and Torres Strait Islander settings, and very few related to the social and welfare context. Most research in Australia has historically been on Aboriginal people rather than by or with, and this can make it culturally inappropriate or unethical. The innovation of the ACCO sector is also not widely published. And there's also, as I identified with the previous study, there's not many evaluations are available and in the public domain. A third concern related to the appraising and selecting of quality studies. We know that evidence-based practice guidelines, they tend to focus on the rigour of the method with little attention to the quality, the cultural quality of the evidence, and also the ethical quality of the evidence. So what I mean by that is, sorry, I missed a slide. I guess in terms of appraising and selecting quality studies, they largely select for high quality, which generally tends to be Western evidence, which is considered least biased, such as the randomised controlled trial or the systematic review. And the least biased is tends to be Aboriginal evidence, such as expert opinion. So I said previously that appraising and selecting quality studies, there's limited attention to the cultural quality of evidence. So this relates to who produces the evidence, why and how they conduct it. In this table, there's two different methodologies for producing evidence. One is towards a Western methodology and one's towards an Indigenous methodology. I recognise these aren't really binary constructs, but it's more just an illustrative table. But the table shows that evidence created by Aboriginal people and organisations from an Indigenous methodology can differ from evidence created by Western methodologies. If we consider the history of research, there's a great deal of evidence created by non-Aboriginal people, which has been created from their deficit understanding from this Western methodology. So knowledge created from a Western methodology tends to have that colonial lens. It maintains systems of power. It tends to be produced towards the quantitative. It's presented as objective and considered neutral, whereas if we consider Indigenous knowledges, it's often produced through an anti-colonial or decolonising or sovereign lens. It interrogates systems of power, and it's from that lived experience based on the realities of those people who experience them. The other thing that appraising and selecting quality studies, the traditional evidence-based practice methods don't really consider the ethical quality of evidence and whether it fits within this rights-based framework and also within national guidelines. Evidence must be ethical and uphold the rights of Indigenous people. Research that adheres to ethics is better quality in that it's culturally safe. The step 4 around the assessing the applicability of evidence across different populations and settings. One of the things is there's limited high-level local evidence. So programs that are tried and tested in places such as North America and Europe are prioritised over grassroots programs. These programs have been created in outsider settings, so they often don't consider things such as colonisation, dispossession, racism, assimilation, and other sociocultural determinants of health and well-being. So it's difficult to assess how the program developed elsewhere may work. There's also great intradiversity within Aboriginal and Torres Strait Islander populations across geographies. So what might work in Central Australia might not work in Melbourne, and what works in Melbourne might not work in the Torres Strait. So a one-size-fits-all approach to Aboriginal and Torres Strait Islanders peoples is probably not appropriate. The third paper that I did do was more of an evaluation of research practice, and this was looking at randomised controlled trials that have been published between 2000 and 2021, and it looked at the quality and ethics of all randomised controlled trials. As I previously mentioned, there are evidence-based guidelines that include a series of steps for doing evidence review, and this is the NHMRC one. These guidelines for evidence review determine that best evidence is on the basis of study design. So studies are based and good quality is determined in terms of the method and not the broader methodology. So in this research, I really wanted to look at the cultural quality and ethical quality of research. Between 2000 and 2021, there were 101 RCTs, and of these, 73 were published. Most of them were pharmaceutical, many were health promotion, a few related to service delivery, and some were clinical and some were environmental, but more than half of them related to children, and a vast majority were for remote communities, and most of them came from the Northern Territory. In terms of who was doing the randomised controlled trials, all of them were university-led except for one conducted by NACCHO, and only 4% of the trials had an Aboriginal lead chief investigator.
Jo, I think you need to move us on to the next slide. That's it. Great.
Okay, yep, sorry. As part of our research, we assessed RCTs, the supposed best quality study design for interventional research. We appraised the cultural quality by looking at who produced the randomised controlled trials. So this one here shows that only 1% were led by an Aboriginal and Torres Strait Islander organisation, 4% had an Aboriginal and Torres Strait Islander lead investigator, 11% had an Aboriginal and Torres Strait Islander first author, and this is a bit more encouraging that 63% had an Aboriginal and Torres Strait Islander co-author, but we don't know the degree to which they were involved in the implementation or the design of that study. So this really provides insights into whose worldview is centred in research using the randomised controlled trial study design. The other thing that we looked at was the ethical quality of the randomised controlled trials, and for that we looked at whether it had the oversight of an Aboriginal and Torres Strait Islander ethics committee, 82% did, whether a community endorsed it, so 55% had community endorsement, 37% had an Aboriginal governance group, 29% were in partnership. Very low percentage, only 7% had sort of data sovereignty and IP protocols mentioned, and only 12% were responding to Aboriginal and Torres Strait Islander stakeholder priority. So it's largely research-driven research. 53% were involved in the design of the intervention, 49% in the implementation, and in terms of the evaluation, only 18% were involved. So our findings show that the cultural quality and the ethical quality of RCTs really did vary, and the ethics are very much inconsistently applied in research practice. Of concern, very few RCTs responded to Aboriginal and Torres Strait Islander priorities. And then this sort of brings me to the future direction. So there really is a need to strengthen policies, regulations and mechanisms to greater support Aboriginal people and organisations to have control and leadership and participation in public health research, evaluation and evidence-based practice. We came up with some recommendations for how we could improve the quality of evidence. So that's how we can improve research and evaluation practice through greater self-determination, Aboriginal and Torres Strait Islander involvement in priority setting, also building the Aboriginal-led evidence base, commissioning evidence of high ethical quality, and that would also be commissioning or tendering of evaluations to better meet ethical guidelines. Greater oversight by Aboriginal and Torres Strait Islander ethics committees. We currently don't have one in Victoria. And also a requirement for community endorsement on projects relating to specific Aboriginal and Torres Strait Islander groups, communities or organisations. We also came up with some recommendations for better review of evidence assessment. And that was, I guess, developing Aboriginal specific evidence-based practice methods, guidelines and tools. So obviously now there is the Aboriginal and Torres Strait Islander quality appraisal tool developed by Harfield and colleagues. And also Aboriginal and Torres Strait Islander perspectives must be central to decision making. Also looking at the evidence and assessing and appraising that. And then these are the 3 publications that I talked about today. So there's the details there. And that's it.
Amazing. Thank you, Jo. That was great. Fascinating. I've had the great pleasure of seeing that presentation twice now, and each time I learn something different, and I just find Jo's presentation really informative, and I love in particular the analysis that you did about the random control trials and Aboriginal leadership of those research projects. We're now going to open up the session for questions. If people have questions and you'd like to put them in the chat, please do. I don't think we currently have any questions other than, can you put the 3rd publication in the link? Yep, we'll do that. In the message, we'll do that. Please do, everybody. I can see lots of people congratulating you and saying how great the presentation was. That's great. I can kickstart the questions. I've got a question here for you, Joanne. I have the privilege of working with Joanne 2 days a week, so I get to ask her questions quite regularly, but I will start this session with my own question and then look for questions on the chat. This is a particular concern for myself as the non-Aboriginal manager of a research and evaluation team within an Aboriginal community-controlled organisations. I'm always looking for ways that we can strengthen Aboriginal leadership of not just what we research, but how we research. So I'm interested in your views on how we can strengthen Aboriginal leadership of research and evaluation projects.
Yeah, I think that largely can come through governance groups as well. Obviously through leadership of the organisations and the collective voice of organisations. I guess it's I see it being done. So yeah, I guess it comes through collaborative approaches really, and that engagement.
Thanks, Jo. I know it's something that we grapple with. I think we're often conscious that it is a collaborative process. It is maybe multiple efforts, both in terms of facilitating processes to articulate a research agenda for an organisation so that it's clear what the organisation's research priorities are, and then looking at ways with just specific projects that you can strengthen that leadership. Yeah. So, okay, here we go. Some questions coming through. I can see one here from Dee. I'm really interested in ways to navigate blockages to co-design and co-lead reforms that are largely due to budget constraints needing to educate up. Have you seen some great tools to navigate this?
I haven't come across any.
Do you think, Jo, that some of the principles that you've talked about and some of the ways that you've talked about improving research would inform better co-design? I think we often all feel that co-design is paid a lot of lip service to. And Dee, please chime in if that is not the direction of where your question is going. But, you know, how do we do good co-design when we're constrained by external factors?
That is the direction I'm going in. Thank you. I appreciate that. We've got a piece of work coming up that's going to lead a major reform, hopefully. And there's a massive blockage due to budget constraints and leadership appetite that may impact the research part of what we are doing. And we are actually wanting to design the reform in community, with community. But we need to be able to get it off the ground through the usual political approvals first.
I think that really, in terms of ethical practice, that should be prioritised. Would you be able to ask the question again? Not really.
Yeah, sorry. I think I'm sort of thinking as I'm talking. Basically, we have some reform work to do. The work is wholly and solely impacting on discrete communities in the Cape or Queensland. I'm coming from Queensland. The reforms, it's essential, obviously, that these communities, you know, lead that work and let us know how that should look and where we're kind of heading. But it is a quite politicized piece of work, and so a lot of the response that we're getting at the moment is there's already been research done in these areas, and that should drive the work. However, the research that has been done is contestable, and it's just really constrained by budget. So you've got a group of people sitting in Brisbane, not even sitting in the communities or near the communities that it affects, wanting to actually go into community if we were welcome, and you know, really almost describe for community what they want to do within the constraints of the program. But there's blockages at every step of the way to try and get to that point. And the reform can't happen without really solid research.
Yeah, that's a really tricky one. I think it really requires the buy-in of the community, and that's really with them. I find it really difficult trying to navigate relationships. But I mean, that's a big part of research and evaluation in this setting. You need to make sure that there is buy-in by community. Otherwise, is your research or work going to be of benefit to them?
Yeah. Thank you.
Great question, Dee. And I see that others are contributing to your question. We've got John saying there would have to be implications for research groups operating in the Pacific region. What avenues are there to influence these groups? John, I don't know if you want to expand on that.
Yeah, hi. Many of the matters that Joe you've raised, I think probably would also maybe reflect research done with other, well, I suppose with Indigenous communities in other nations. And I'm aware, for example, DFAT is currently funding quite a bit of work. So, for example, in a few weeks' time, there's a Fijian delegation where they'll be receiving evaluation training through one of the universities. So it seems to me that there's a lot of things people could learn from your research. I mean, obviously, your publications are one avenue. Your presentation today is one avenue. There's probably maybe even other formal avenues, like even influencing DFAT and conditions it places on funding it provides. And I'm just thinking at a practical level. I know the people delivering the training, and I know they're well versed in the importance of what you're talking about. But I would think that DFAT could build into some of their funding of organisations who will be delivering research training, evidence-based training, evaluation training, to build some of the principles and lessons learned from your research into their funding of those organisations. So I just think there's probably a lot of other direct avenues in which the results of your work could influence how governments fund research groups, for example. But that is, yeah.
Yeah, that's a really important point. I think one of the things we were able to do is sit at a desk that's near Catherine Chamberlain. So she has a large voice on the NHMRC. So we were able to present the findings to the NHMRC, and they're currently reviewing some of their grant funding schemes. So I think that was a useful thing as well that we were able to do with this research.
Thank you.
Some other comments that are coming out here. Then from Sharon, there needs to be Aboriginal-led co-design. Alison sharing some tools for culturally safe evaluation. Jody saying rapport building in the community takes time and it's not something that's measurable. But as you said, Joe, it's so critical to building buy-in for later on implementation, given the importance of so many research projects to service delivery. Alex, thanks for sharing that information about the Australian Education Research Organisation's model. Every project they conduct goes through an expert reference group, currently made up of 230 paid members from Aboriginal and Torres Strait Islander communities. And also Sharon for sharing the link about the Aboriginal Health and Medical Research Ethics Council. That's great. Do we have any other questions from specific questions from the audience? We've still got more time, so there's no need to be shy. No more questions coming through. Final call. Nice question from Sarah to you, Joe. What do you want to do next, Joe?
Yep. Well, I'm currently looking at VACCA, and there's a senior research officer, and I'm happy to be working on projects related to what VACCA has chosen to do. So responding to community-based priorities, and also in my other role, I'm looking at dementia, which is going to be a increasing health concern over the next sort of 30 years. So looking at data related to that. Yeah. I like epidemiology, but I sort of went off on a I guess, a evaluation sort of tangent and just whatever I was interested in for the PhD, but interesting to get back to data.
Nice.
Thank you,
Sarah. And I can just say that Jo's helping us to keep an eye on our practice as well in our team at VACCA. We work very closely with program staff. And as Jo said, we work on research topics that are determined by the organisation. Wondering how Jo sees incorporating her PhD research in her future work, from Alison.
I guess in terms of my approach, it's guided by the ethics that I've learned about in a lot more detail. So really about trying to engage, I guess, people that the research relates to in that research. So in terms of some of the work we're doing at VACCA, really engaging with staff working in the programs and Aboriginal staff working in the programs, and getting their perspectives into the research and the analysis as well.
Thank you, everyone. If there's no more questions, I'd like to close us off by thanking Joanne for doing the presentation. I think her PhD was really a fabulous piece of work, and it really helped to validate the work that we're doing at VACCA and the way that we're working, particularly around standards for evidence and what we consider to be evidence. So thank you from me, and also on behalf of the committee. I can see all those nice messages from everybody thanking you, so we'll make sure we keep those and pass those along. And thanks everybody for joining us on a Wednesday afternoon.